respect to it. And Marzia, you're meant to be up here with me, as is Ioannis Kakisis. Right, could I very much encourage you all to stay for this session, and I think the next person to talk is Steve Elias. Steve needs really no introduction. Steve comes from the United States of America in New York, and if there's a new technology, you can bet your bottom dollar that Steve is doing something with that technology. So Steve, do you want to tell us very briefly, and I will keep everybody very much to time, to tell us about HIFU?
Now it's on. It was after. Okay. Anyhow, so let me quickly let you know about high-intensity focused ultrasound. What is it, and maybe where does it fit in? And thank you, Alan. Yes, we like new technologies because they're always interesting. So these are my disclosures. Back in 2014, I kind of came up with the terms of thermal tumescent and the non-thermal non-tumescent and endovascular today, and those are the two that people have been using for a long time now. But there's a new area that instead of now TT or NT, there's a TNT. So what is TNT, aside from being dynamite? TNT is a thermal non-tumescence, and you can see all the things we have, but really I'm focusing down here on high-intensity focused ultrasound, and thus far we only have one of those. These are all the newer non-NTNTs and TNTs, but again, we're going to talk just down on Sonovane. So what is this? This is a device. It has a cooling system here. You can see there's a touch screen, but the main working component is the VTU, or the visualization and treatment unit. And what happens? There's two ultrasounds here. One is an imaging ultrasound. This is showing up, right? Yeah. One is an imaging ultrasound that's going to show you the vein you want to target to treat. And the other is a concentric ultrasound that's going to come down to a point. Think of it like an ice cream cone. And at that point, heat is going to be generated when high-intensity focused ultrasound comes to a point, and you're trying to focus that point on the saphenous vein that you want to occlude. And this is, it's done in the office. There's no prep. The patient wears a pair of shorts, pull up their shorts, you image the vein, and then you kind of work your way down the vein. So this you can see on the left, you're heating up this tissue here, and then you can see it gets much thicker. You can document that you've treated that segment of vein, and you can toggle back and forth to see before and after, so you know you've destroyed that level of the vein. And what are you doing here? You're working your way down what I call the rungs of a ladder. So the vein gets compressed by the machine, by the head, and then you mark where you want the machine to zap away, and you zap away usually 3 to 4 segments across the vein. You go down, just like the rungs of a ladder. You go down, go across again, go down, go across, and it's 3 millimeters in between each one. So you're zapping, going down, zapping, going down, zapping, going down. That's the concept. I just thought it's an easy way to look at it. We did an initial study in the U.S. It's already been used in Europe for a while. Did 20 GSVs, and you can see here the usual suspects, but the diameter was 7 millimeters on average. There was no anesthetic used at all, not even a needle stick for any local anesthesia, and there was no post-procedure compression, and ablation. Reflux was taken care of 95% of the time. Pain was 20 out of 100 or 2 out of 10, and there were no nerve injuries. And of course, the VCSS goes down if you decrease the size of a vein. Now there's U.S. data that there's 4 places this is being used in, 2 in Europe, 2 in the U.S. Tony Gasparis and myself have been doing this. This is the 35 patient data. At 1 week, 31 of 35 were closed, but it takes time for the vein to shrink down. And then you can see as you get to 3 months, 24 of 26 that we followed to 3 months are closed. And then once you get to 6 months, all of them that we've imaged thus far are closed. And, you know, we're looking at the rest of the patients over a time very similar to the initial data. So finally, what are some thoughts? It very definitely works. There's no question about it. It works. The vein needs to be between 12 and 22 millimeters from the surface of the skin when it is compressed. I would do veins 10 millimeters or less, just like I say for a lot of the other non-thermals, although this is thermal. Local anesthesia, if you need to, you place it below the vein, right between the vein and the muscle. That's where the pain and discomfort happens. No compression afterwards. We only treated about 15 centimeters, and the whole procedure takes about 45 or 60 minutes right now. But AI is being now utilized for the next generations, probably double the distance. There's other techniques and technologies going to be improved. I think it's going to find a place. Is it for everybody now? No. Maybe short ASVs, short GSVs, perforators for sure, and maybe even a transcutaneous Shiva. So, think young, don't think nothing new is ever not going to work. And this is how I kind of live life and look at the world and the vein world too. Think about the elders, embrace the new, and encourage what you think is improbable and practical without bias. And you want to hear more about this, go to venusedge.com. It's the online video magazine that a lot of people on this panel have participated in when we've done interviews. So thank you.